Perfect. So this case, this lady is a Gravida 2 Para 1. She had a previous SVD in 2021 and the baby was SGA, I believe, around the 5th centile. Low risk at booking otherwise, had a BMI of 30, pretty routine care during pregnancy, but she had an additional scan due to previous SGA at around 37 weeks. Baby was cephalic, normal fluid, estimated fetal weight on the 5.6th centile, and a raised umbilical artery PI on the 99th centile. So due to this, there is a risk factor. An induction of labour was recommended and for the abnormal Dopplers, and so she was decided to have an induction at 37 plus 2 on our labour ward. So prior to PROPES, she's on labour ward here. This was at around 12:30 p.m. daytime. She had a good 30 minutes of CTG, as you can see, and then had an examination at 1 p.m. Cervix was 2 centimeters dilated, presenting part -2, and a PROPES was inserted. Blood pressure 112/79. Sorry, I'm just trying to get rid of that bar. It's annoying. Pulse of 106, respirate of 17. I think that said 36.6 was her temperature. So initial thought process, obviously we're looking and thinking, okay, we've got a baby that is small for gestational age with abnormal Dopplers. How well is this baby going to cope with labour? So just having that in the back of our minds. Baseline sort of settles down towards the end here around sort of 125, 130, which is normal for the gestation that we're at, which is good. Some nice acceleration, stable baseline, and good variability here. This is post-PROPES CTG, so this is the sort of next 50 minutes of trace. Anyone got any concerns? I'll take that as a no. Oh,
no, Dagmar's got her hand up.
Go for it. Just shout out at me, Dagmar, because I can't see anybody. So just shout out.
Okay, sorry. I am wondering why PROPES was used in comparison to mechanical dilators.
We have recently stopped using Dilapan in our trust. I think just due to the benefits not really being seen with that, and I guess Cook's balloon just wasn't the recommended situation in this case, really. Normally, if we've got a baby that's sort of under the 3rd centile and like severe IUGR, we would use some form of mechanical induction. I don't know if anyone knows the guideline better than I do, but I'm pretty sure they have to be slightly more SGA before we would consider that.
Okay.
Hi, Karen.
Yeah.
Just like Dagmar is asking, we only know about the dilatation. What about the other parameters of the Bishop score?
So she was 2 centimeters dilated, presenting part was -2. The cervix, as far as from what I can remember, was thick and posterior.
Okay. Thank you.
No worries. Dagmar, do you know, like, from your own research, because I consider you as a guru when it comes to research, what the sort of recommended, like what centile babies are necessarily supposed to be under before it's recommended for a mechanical induction?
I'm not aware that there is any kind of agreement, to be perfectly honest. You mean gestation and SGA? I'm sorry, I just need to make sure that I understand the question correctly. When it comes to when to be induced, there it's probably the IUSG, the International Society of Ultrasound and Obstetrics and Gynecology guideline that is beneficial there. Although the most recent one that they essentially put out, and I can only recommend to have that in your pocket, literally, it's actually something that I refer to frequently, is more for early onset IUGR, and when you should be delivering. So it's very clear about when do you deliver. For the late onset growth restriction, and I do not know if this baby had always been small or if it was a late onset one, there is nobody goes beyond 39 weeks, and that is because there hasn't been any evidence for holding on for longer. But there was a trial, and I can't remember the exact name, I think GRIT, that looked into the small babies, so below the 10th percentile, if they would be below the third, I believe they looked into if they would be better off induced at 37 or 38 or 39 weeks, and that essentially showed that there is a trend to poorer outcome after 38. So therefore the timing of induction of labor is perfectly okay. The how, there's no guideline out. But it is, the idea is essentially just if you think that the placenta has difficulties and you have a high umbilical artery PI, which indicates exactly that, no? So then that you have essentially kind of more flow difficulties, then the idea would essentially be to kind of keep the placenta as uneffaced as you can for a long period of time, and hence my question for mechanical means. Therefore, a Cook's balloon has a potential disadvantage because it has a 80 ml balloon in utero and an 80 ml balloon vaginally. It is good to make the neck of the womb softer, so it effaces it more, but it also dislodges the presenting part, no? Because you have an 80 ml balloon underneath the baby's head. So they normally need a longer time to come down, whereas Dilapan doesn't have that. But a disadvantage of Dilapan is that if you remove them and then you don't go on with an ARM, the cervix essentially retracts back after 4 or 5 hours. So therefore you can only use that if you don't have any delays. But then it actually showed in the trials, at least, it was very good. But yeah, I haven't audited any data in any trust that I've worked with Dilapan. So I do not know.
I think due to the fact that we were obviously experiencing delays with obviously Dilapan being removed and then delay in actually getting them over to Labour Ward for said ARM, and I think that's probably why they stopped being used as frequently to the point where we now don't use them really at all anymore. So Cook's balloon would be our other option, but that's really interesting. Specifically, I think with this case where she's SGA as well as abnormal Dopplers, I guess maybe mechanical induction would have been, well, almost safer, if you like. But by all means, we're keeping very much a close eye on this baby, essentially. SGA, we normally do CTGs 4-hourly for process of induction anyway, just because we're well aware of the fact that babies are more likely to become stressed as opposed to a baby that's sort of normal centile, normal Dopplers, etc. Cool.
What do you tell women about the risk of hyperstimulation with ProPES?
That's normally a conversation that a registrar would have with women when we are having that kind of conversation, when we're discussing induction and whatnot. But from what we've discussed actually on here before as well, I think it was you actually, Dagmar, that discusses with us, but the risk of hyperstimulation is sort of 4% with ProPES.
Correct, yeah. So the advantage is essentially that you can remove it, but it's not an insubstantial risk.
Yeah. But obviously, if that was the case and a woman did become hyperstimulated, then it's somewhat of a fix whereby we can remove the ProPES and then give tocolytics if necessary. However, hopefully we wouldn't get to a point where it would come to that. But yeah. So this is the CTG continue. So this is a little bit, I think this is a little bit later on, a couple of hours later. Blood pressure remains normal. Pulse is slightly raised, I think, from what her baseline pulse was. I wonder if this was starting to sort of become a little bit more painful for her, or maybe sort of anxiety induced, but she was well hydrated on antenatal ward and whatnot. So So yeah, respiration rate 18 and temperature of 36.4. She started to pick up the contractions quite quickly. So this Propass had quite a quick effect on this lady. And she requested some pain relief at 4 p.m. and she was given some dihydrocodeine, which is one of our sort of baseline drugs on our antenatal ward. Baseline remains similar to what it has been before. We've got those nice accelerations, which are a great indicator of fetal well-being. So yeah, this continues. And this was a little bit later on. At 17:45, because she was becoming increasingly more uncomfortable, the decision was made to do an examination, and she was found to be 3 centimeters dilated, so it already dilated a centimeter, and her presenting part remained at -2. It still wasn't fully effaced, or anything like that, and waters were still intact as well. Baseline has sort of risen slightly here, up to around sort of the 140, 145 mark, but not necessarily concerning enough at this point for us to remove the Propass.
Why would you not remove the Propass? She's 3 centimeters.
Well, the thing is, this is always a conversation that we have. The idea is that the Propass remains inserted for a period of 24 hours, and if there's no signs of sort of hyperstimulation, I know that the whole point of Propass is to sort of ripen the cervix, get it open enough for us to do an ARM, and then continue with the induction that way. But if there's no availability for her to then, for example, go over to labour ward to have said induction with that method, then we wouldn't necessarily need to remove it at that point.
No, but even if you remove Propass, so if you think that all of this uterine activity is due to Propass, then it might die down, but it usually doesn't do so entirely, particularly not in a multip. So they continue to contract, but less frequent. And given that you're not risking anything because she definitely remains ARMable, isn't that then the safer option? Because my next question for you would be, do you think you can ever discontinue this CTG given this uterine activity?
No.
So therefore she would be then on labour ward for nothing else but monitoring, no?
This is very true.
So why not remove it? Because you know that you're not losing anything, you're just safer.
It's a very good point. A very, very good point. This is then continue. I think she is then transferred over to labour ward from this examination, and I think the plan was made to obviously do an ARM and induce her further. So this is the sort of time between here. So at this point, she's transferred over to labour ward. I think the Propass might have been, sorry, I should have said that. I think the Propass was actually removed at 17:45. Sorry, I haven't actually written that down, but it's on my notes that I've just found for this case. So cervix was 3 centimeters dilated, presenting part -2. The Propass was removed at this point because obviously she's progressing well and she is much more ARMable than she was at her 2 centimeters earlier. I mean, arguably, if the cervix was open 2 centimeters, somebody could have performed an ARM to begin with. So it was just a decision as to whether the clinician that was performing the vaginal examination in the beginning would have thought that this woman would have been ARMable. But this is another debate we have sometimes on our antenatal ward. Obviously there is a risk of 4% of hyperstimulation from a Propass, but at the same time, if we, for example, had someone who was a primate who was being induced for post-dates or something along those lines, and she was ARMable from the start, or a difficult ARM, I don't know, a 1 centimeter or something along those lines, would we rather try and ARM her and what they would call, some people call a dry ARM, or would we give her Propass to try and ripen the cervix so that an ARM is more manageable, but also so that she has the opportunity to try and progress with a hormone before we then trying to induce her further, specifically if she's going to be waiting for a prolonged period of time on her antenatal ward before she gets the chance to go over for an ARM.
the question that you're asking is it faster? No? Because the only reason to kind of give prostaglandins is if it saves you the time of one-to-one care and syntocinon. From the management point of view, isn't it?
Yeah, absolutely. But the thing is, if you're, for example, doing a vaginal examination in an ARM on someone that's 1 centimetre dilated, that cervix or woman has never laboured before or ever had a cervix that's remotely been opened before, do you want to give something like oxytocin, which is an incredibly strong drug, in order to induce her labour from scratch? Or would you rather give her more of an opportunity to be much more mobile and to not be attached to a CTG for a prolonged period of time, give her more of an opportunity to be able to get labour going a bit better from that aspect, as opposed to starting a hormonal drip?
I guess the only person who can answer that question to you is the woman in front of you. So if she essentially, you know, and hand on heart, and sometimes in primaps you can't do an ARM, but have you ever done a VE on a multip where you couldn't have done an ARM? I mean, we all could if we wanted to. So the question is essentially, is that in her best interest? So the advantage of syntocinon is that it's far more controllable. You can stop it, no? Right. But the disadvantage is that you need one-to-one care, continuous monitoring, and then therefore essentially everything that goes along in a unit that goes along with that. No? So it's far more labor intensive and personnel intensive. And I'm afraid it really comes down to exactly that. So therefore, in a primap, I would therefore have a lower threshold of trying to soften the neck of the womb in order to reduce the overall time that she's on syntocinon. But as far as I'm aware, there's no evidence that given propes followed by syntocinon makes anything shorter than just being on syntocinon for the entire period of time. So you're actually equally quick, but you don't have the same, or equally slow, however you would like to kind of phrase it. But you have essentially significantly more mobility on progress, or prostaglandins in general. But if the controllability, i.e. an IUGR baby with reduced flow in the placenta, is the forefront, so safety, then I wouldn't go for that necessarily, no. Then I would have a far lower threshold of correlation saying, well, I think you need to be monitored anyhow most of the time. So
Yeah.
I either use mechanical means or I do an ARM and essentially have you then on labor ward. Yeah.
This is where Mr. Naguib would probably come in and say something along the lines of, this is why obstetrics is very much an art.
Indeed.
Because
there is no fixed rule to it. So there isn't. So therefore you can argue it both ways. And I'm totally open for anybody else in here. I'm just saying you will ask 3 obstetricians and get 3 different opinions.
Yeah, exactly. And it's this is why I find these case reviews even more interesting for myself as well, because, you know, you could play this one of a handful of ways. Induce with mechanical, give her the opportunity to progress without the risk of hyperstimulation and whatnot, and the hormonal changes and things like that, giving her prostaglandins or any form like that will help ripen her cervix, give her more opportunity to sort of move around and whatnot. Is that more beneficial to the woman as well? And this is why as well we need to have these conversations with our women, because actually if she was given the 3 different options, I wonder what she would have made the decision on. And this is where, you know, we're looking at the whole clinical picture here. We're not just thinking about the baby, but we're also thinking about, okay, given the opportunity, what would a mother decide to do too, which is also such an important part of CTG analysis, because these women need to be well informed.
Correct. So therefore I would always think, ask the woman and be safe. These are the kind of 2 priorities, no? Maybe in the other order, but yeah. So therefore I would use mechanical in order to be safe, and I would ask the woman when it comes to the kind of 2 options of either ARMing her or using anything to mechanically or kind of with propus dilate. So, and then obviously the other option is the other kind of thing that you need to take into account is workload, because if you have a damn night where you really can't kind of cope, then there's a long wait before you can ARM somebody and essentially use syntocinon, so you have a backlog.
Yeah, absolutely. And a one-to-one care case is going to take up, staffing dependent and whatnot. A one-to-one care case is going to take up more time and more staff than it would if this was somebody being looked after alongside 6 other patients for one midwife. I realised I've made a complete mistake here because she's on labour ward whilst this is being done. So ignore everything I've said about her being on antenatal ward and being moved. Apologies for that, guys. It's been a long day. But yeah, so she's on labour ward anyway, and that's where she's being induced. So I'm assuming, going by that now that I've actually reread my actual notes on this case, that the reason that she was being induced on labour ward was due to the fact that she was SGA and we needed to keep a closer eye on this baby, as opposed to having a 1-to-6 ratio with the midwife on antenatal ward. However, I do know full well that this woman wasn't a 1-to-1 care case on this specific day. She was also, the midwife that was caring for her was also looking after a postnatal woman. So obviously before that, she's sort of still splitting up her time, but can obviously take more attention to care when she's only got one other person, as opposed to a midwife on antenatal ward, which may have 6 or 7 or 8 or sometimes less than that. But yeah, when she was examined, she was 3 centimeters dilated. The PROPES was removed, and the CTG was continued. She, at this point, requested an epidural, so she was sat up into the position for the epidural. And at 18:05, Hartmann's was started. She was sat upright, and then at 18:15, her epidural first dose was given. Obviously, we've got quite a significant amount of loss of contact here. I am repeating myself repeatedly when it comes to how important our fetal monitoring is during the epidural siting, specifically if we do have any CTG concerns or anyone at high risk. Again, with a baby that's sort of SGA, possible RUGR, we know that we've got a 10% margin of error when it comes to growth scans at late gestation in pregnancy. So actually this baby could be a few hundred grams less than actually we initially calculated. We need to be much more aware of this, making sure we're getting a second midwife available to help with the epidural siting, or getting the ODP to be called by the anaesthetist in order to support the midwife so that she can actually just sit and monitor this baby without having to sort of help with any additional things. But yeah, blood pressure remains again stable. Pulse has come down to 88, respiration rate of 17, and a temperature of 36.8. Test dose followed by a deceleration for about a minute, but recovers nicely back to baseline. And then we continue. This TOCO was adjusted quite a few times and was zeroed very frequently whilst the epidural was being sited. And again, after the test dose had gone in and she was sat back up into position. But the contractions are something that I wanted to draw people's attention to, and specifically in this one, because what's not documented here is any mention of resting tone on palpation of this woman's abdomen. And again, this is one of the key themes I mention on a very, very regular basis, that we really, really need to be monitoring and feeling the contractions of a woman, and documenting that really, really clearly in order to be able to assess if this woman's got any resting tone. Because something that Austin Ogwamadu from St George's will always say is actually the time between the contractions and that resting tone is actually more important than the contractions itself, specifically when you're analysing a CTG. And if you count all the small bumps that she's having here, which you could argue are contractions, it looks like she's having about 9 contractions in 10 minutes. But maybe adjusting the TOCO, moving it around the abdomen to try and get a better representation of those contractions would have been an idea here, but unfortunately that's not documented anywhere. So this is where our documentation comes into play as being incredibly important.
I would also ask myself, so the PROPES had been removed at, you said 3:45?
Yeah, 17:45. So we're now towards the end of this CTG. It's been an hour.
So if PROPES, ideally, so if you would remove PROPES and you wanted to start Syntocinon, in theory, in a patient, you need half an hour in between the two, no? So that's essentially according to the license of kind of PROPES. So therefore you would normally expect, if you remove PROPES and all of this was due to PROPES, I'm not saying that it always works this way, then you normally shouldn't be having this anymore. So I'm therefore now thinking, what are the two other alternatives of having this degree of irritability? So it might still be that PROPES got absorbed and removing it is not doing the trick.
Mm.
And the other options is abruption and infection. So because all of them cause uterine irritability. And then I would be looking for what do I have evidence and what am I fearing.
Yeah, absolutely. Also, if we've got a rising baseline, although it's not what we would call, under the sort of guideline, what we would call significant more than a sort of 10% increase in the baseline at this point, it looks like it's rising towards it, which could then give us an indication that this is possibly infection if you're putting 2 and 2 together with this uterine irritability. However, obviously this is more likely to be a fetal infection due to the fact that mum's observations are very much stable. So we continue. As you can see, our baseline is very much increasing. Towards the end of the CTG, we've got a baseline of 160, and our original was around 125, 130 from prior to any kind of prostaglandin insertion. We've still got that very much irritable uterus going on here. Bleeding was assessed. She had a catheter inserted here at 1920. There was no blood loss reported or anything like that at all. So we've ruled out the possibility that this might be abruption, unless it's completely concealed. But again, no documentation of uterine contractions or palpation. But we have got some chemoreceptor-mediated decelerations here. And our baseline has increased. And I'd actually argue as well that our variability is reduced as well.
Sorry, Cara, did she shrum?
Not that we're aware of.
So she has intact membranes and no blood is visible.
Yeah.
Okay.
What are your thoughts, Dagmar?
Well, if you think that this baby is essentially kind of now, so it started with 130, it's now it has a base rate of 160. The variability appears to be reduced, and I can't see cycling anymore. So you have to do something about the contractions, right? So you definitely do not want to kind of rupture the membranes, but my question is, how certain can you be that this is not an abruption? Because if you can't rule that out, you can't give terbutaline or salbutamol, whichever it is you're giving.
Yeah.
So therefore, if you can't rule that out, then you would need to do an assessment to see if she's pretty much deliverable. If you are daring enough to do an ARM to see if there's blood stained liquor, with knowing that your theater is free if you needed to, right? And give terbutaline at the same time, to knock the contractions off, then you could potentially continue this, but you're taking a lot of risks with this. So therefore, this is a CTG that I would escalate to the most senior person on.
Do you not think that that's sort of counterproductive, though, to do an ARM and give terbutaline at the same time? It just feels like
I wouldn't, but neither am I convinced that I can give it without it. So I can't sit on the CTG because it has a base rate of 160 reduced variability. No, so we know central organs are perfused if I have a stable base rate and normal variability. So if I think, right, there's so much uterine activity, there's a problem underlying, I would need to do something to counteract it. So what do I have to counteract contractions?
Yeah, that's very true.
Okay, so if I talk about tocolysis, then I need to be absolutely certain to rule out an abruption. So if these membranes are intact, how certain can I be? So then you literally would need to kind of go into theatre, give the terbutaline and say, well, we're waiting here for about 20 minutes to half an hour. Because that's the alternative, not breaking the waters, giving terbutaline and say, well, if this doesn't work, then I'm afraid you know, if this doesn't make your baby any happier, then we'll have to go for a cesarean section, because really, how long would you like to keep it this way?
Yeah.
Because that's your alternative, but you would need to be in theatre, because if you do give it with an abruption, you have about 10 minutes before the placenta might or might not be abrupting completely.
Again, Mr. Naguib would say this is why obstetrics is an art form.
Ooh, I agree with him there, but do you think that he would be doing something differently? Because I think I can't leave this baby like this. I need to resuscitate it. So therefore, first thing is assess the situation. If you can swear that there's no abruption, please feel free to kind of give terbutaline. If you can't, then the only place where you can do that is literally being in theatre.
Yeah,
Yeah.
absolutely. So, at 1940, this woman reported feeling pressure. She was examined and she was found to be 4 centimeters dilated, so she is in active labour. As you can see, the CTG hasn't obviously improved. Baseline still remains 160 with reduced variability and more decelerations. Blood pressure remains normal at 114/73 with a pulse of 89 and respiration rate of 17. Also, the temperature is 37.4, which is quite a significant increase from the 36.6 it was sort of half an hour, 40 minutes before. This was escalated and the doctors came into the room at around 2015 and the CTG was defined as being pathological at this point. This is obviously under our FIGO guidelines that we're currently using. The one thing that's kind of reassuring for me that this maybe isn't an abruption is purely based off of the maternal observations. Now, obviously, there's been cases, and there are many cases where abruptions that are concealed are very much concealed to the point where there's very, very limited sort of evidence to suggest that this could be an abruption. But normally, routinely, if you are having an abruption, there would be some changes to maternal observations. Being that she may be slightly more tachycardic, blood pressure may be slightly lower and whatnot, which makes me think when looking at this, well, made me think when I looked at this initially that this was more likely due to infection as opposed to anything else. But
I do agree. I have the same impression, but unless you're clinically there and can rule it out, it's very difficult. But so, as I said, so if you felt this was infection, what would you do, Cara? If you essentially had the kind of clinical conviction this was an infection, what would you do?
If this was something that, I mean, the thing is, this doesn't appear to me like the mum's infected until we got to this point. Based off of the whole clinical picture here, despite the fact that we've not got tachycardia or a temperature of 37.4, or a temperature that's sort of out of range, if you like, I would still sort of try and treat this CTG. Not try and treat this CTG, sorry, treat the mother and give antibiotics, although I'm more convinced that this is something we've maybe missed, that she's Schrom, or it could have been a hindwater leak that we've missed. And obviously, because forewaters are still felt when it comes to the cervical examinations, that this is more sort of choreo based. And we've got raised baseline for gestation, specifically more so than we normally would. We've got presence of decelerations, which normally wouldn't be associated with choreo preceding a rise in baseline, but our baseline did sort of go up before the decelerations occurred. I would sort of treat this as a fetal infection, but I would treat the mother with antibiotics.
Interesting. I see that Sophie is on the call. Just to kind of, I do not know if you can speak, Sophie. Is that what you would do in your trust? Because I'm at the moment in a trust where they would also kind of start treating with antibiotics. So same here, Cara. Is that what you would?
I think it would. I think it would depend on a case by case basis. We probably wouldn't give antibiotics. We'd probably give paracetamol. I think that's probably what we would end up doing. I would imagine.
Would you give terbutaline to just kind of calm the kind of infection down in the hope that this is a primip, a multip who's going to labor really fast?
Most probably, yes.
Yeah.
We would. And we would have given it before on the previous CTG.
Yeah.
I would
So,
imagine. Because from what I can see, it just looks like it is hyperstimulation. I mean, the fact that there's a temperature there is throwing me off, but my first impression was this is due to the ProPES hyperstimulation with an IUGR baby. That was my thinking.
well, I would definitely give terbutaline.
Yeah, okay, good, yeah.
Antibiotics would
Waiting for you to
follow
agree.
that, so, I'm not too fussed about sooner or later because the mom is not septic. So, and given that there's very little evidence that I'm really reaching the kind of baby in therapeutic doses in utero, the first thing is make the baby happy. Make sure the temperature is going down, because if that's contributing to it, do that. And everything else is following this. Yeah, that would be my thinking.
Yeah,
Perfect.
correct the CTG.
Yeah.
Improve the environment for the baby. Sorry, there's a baby there. Need to stop calling it a CTG.
Yeah,
The baby.
absolutely. Perfect. This was obviously defined as pathological, which was obviously escalated. Terbutaline was given at 2023, and at 2024, the decision was made for an emergency cesarean section. Confirmed with the consultant 20 minutes later. We know that terbutaline can obviously cause a slight rise in baseline, but we've already got a raised baseline anyway. But it does sort of go up a little bit in the areas in between, although the variability seems to have improved because there's no uterine activity, so slightly less stress on this fetus. But yeah, I think we all be in agreement with this decision making?
Yes.
Yes, in view of the outlook that even in a multip, you are not in labor at 3 centimeters, you're still in the latent phase.
Well, she's 4 now.
Well, there's another VE down here that states 3.
Yeah.
So therefore, it might be the kind of inter-observer kind of variation. But again, I would have a conversation with the kind of woman, and I would say, right, so it looks as if we're having an infection. Difficult to kind of say where that is coming from. But you definitely have far too many contractions with that, and I can knock them off for a short period of time. It lasts for about 1 to 2 hours, no? But then it will essentially kind of come back with a vengeance. So unless I anticipate that you're laboring that fast, yes, so that I will not need to kind of give a second one of this, or I will be kind of then looking into delivering you. And that, I'm afraid, is at the moment not very likely. If it's a 3 centimeter thick cervix, I would definitely go for cesarean section. If it's a 4 centimeter paper thin cervix, I would have a conversation about, well, if you're really keen on trying for a normal birth and a really small baby, I would be at the moment still with you, but you just need to be aware you have a very high risk of having an emergency cesarean section, and I'm happy to map out under what circumstances I would highly recommend that. So again, it's a mixture between me recommending something and the woman taking that on board. No?
Yeah.
Sorry, alarm in the background.
Perfect. This was our CTG in theatre, knife to skin at 21:08. She had a spinal top-up, epidural top-up, sorry, and then delivery was at 21:10. Anyone want to guess the APGARs or the gases for this baby? Remembering that this isn't necessarily hypoxia, this is more infection related or possible infection related.
If the baby was really IUGR and had a bit of kind of hypoxia on top of that, then I do believe that there's probably a little bit of resuscitation for the breathing, for the establishing of breathing required. If there was meconium during the delivery, then that might be more pronounced. But this baby, because there wasn't significant hypoxia, might be amazingly well. And entirely depends on the buck, really. But I would also keep an eye out for the next 12 to 24 hours, because that is then very often when the baby show that, so that they get hypothermic or tachypneic. Yeah.
Yeah.
Was the delivery uneventful? Like
Yeah.
it wasn't like you're not going to throw us a curveball of like head entrapment or something.
No,
Yeah.
they got in. It was very much straightforward. Knife to
Okay.
skin and delivery within sort of 2 minutes of each other. So
Okay, good.
don't worry, I'm not trying to trick you.
I wouldn't put it past you, Cara.
I know.
No, then I agree with Dagmar. To be honest, whatever Dagmar would have said, it would have said I agree with Dagmar. So
Perfect. This baby was born with APGARs of 9, 10, and 10. This baby was 2.2 kilos on the 1.6 percentile, so 100%
tiny
IUGR.
baby.
Yeah, really tiny. Arterial pH of 7.09, base excess of -10.3, and a lactate of 9.3. Venous pH of 7.15 and a base excess of -9.1 and a lactate of 7.3. So our gases were also somewhat indicative of hypoxia as well, due to the sort of low pH we've got there with arterial, although clearly was very happy at delivery, so happy to be out of that hypoxic environment. But yeah,
It is if a baby has an infection or is surrounded by an infection and the metabolic needs are higher, the oxygen demands are more, and
yeah,
you don't have that much buffers. No?
no,
You essentially are using them to fight an infection, or babies use them in order to fight an infection, which is the reason why the combination of infection and hypoxia is so detrimental, because they very often just can't sustain it for the same period of time, particularly not if they're IOGR. So therefore, good call.
yeah,
Yeah.
really good call here. Do you know, I looked back on this one earlier just before I left work, and I was, when you briefly sort of skim something, you think, oh, it wasn't that bad, and then it just goes to show you do need the whole clinical picture. And this is something that I always say to everybody, and I go around to label and I look at our sort of central monitoring. It's my first job every single morning to go and check it, and I'll look at the CTGs and I think, okay, they look fine, and then I have to check myself and remind myself I don't know anything about the patients that are in these rooms and what those CTGs actually mean at the time. For all I know, that could be completely abnormal for this baby. So it just goes to show you, you need to look at the complete overall clinical picture of every single situation and every single CTG that you look at, because something from afar may be fine, but actually when you look closer into it and you get all of the information that you need, then these sorts of things can surprise you.
Very, very valid. I had a really bad outcome where I didn't take the entire situation into account. So therefore, that was my learning curve. But
Yeah.
But you do not want to kind of have to learn it that way, So
Yeah.
Yeah.
Absolutely.
Tara, can I clarify? Did you say she was given IV antibiotics?
No, she wasn't.
Oh, okay. Were they considered?
No.
Oh.
Did the mother have ever any temperature or was unwell postnatally?
I think the mum had a temperature postnatal, and I believe this baby was screened and treated, but there was no infection found within the baby. The cultures were normal.
May I just ask why you? I can only see the last name. Nanga. Sorry if I'm not pronouncing. Beatrice. Sorry.
Yeah.
Sorry, Beatrice.
Yeah.
I'm curious about your kind of point. Do you think that antibiotics would have made a difference?
It's because when we were waiting and the baseline kept going up, and then the temperature shot from that 6.4 to that 7.4.
Mm-hmm.
So I was wondering whether we are getting to infection for the mom.
I mean, I think every mother gets a shot of antibiotics during a cesarean section, so I
Yeah.
believe that would be the same here. So she would have gotten one shot. And if we think that the infection is surrounding the baby, i.e. is within the membranes or the amniotic fluid, by removing the membranes and the amniotic fluid, is that then not the cure?
Yeah, for the baby.
Why would it not be the cure for the mother?
Well, if there was,
Mhm.
if it had not gone into in the bloodstream as such, and she's given the IV antibiotic in labor, the IV will take care of that as well as the baby coming out.
Yeah, so the actual kind of treatment for chorioamnionitis is delivery.
Yeah.
Yeah.
Absolutely. And we don't mess with choreo.
Very interesting case. Very nice, Cara.
Thank you. I've got a good one for you next week, which I would actually appreciate everyone to attend again, because this one is I'm bigging it up a little bit, but would be really interested to hear shared opinions on next week's case. So watch this space, and thank you all for coming.
Thank you so much, Cara.
Thank you, Cara.
Thank you.
Have a good
No
evening,
worries,
everybody.
guys. Have a good evening.
Bye.
Thank you. Bye.